The metabolic response to injury is a complex and dynamic process aimed at restoring homeostasis and repairing damaged tissues. It involves a cascade of physiological, hormonal, and metabolic changes triggered by trauma, surgery, burns, or other injuries. This response can be divided into three phases: the ebb phase, the flow phase, and the recovery phase. Each phase is characterized by distinct physiological and metabolic alterations. 1. Ebb phase, initial phase. This phase occurs immediately after the injury and lasts for about 24 to 48 hours. Its primary goal is to maintain perfusion of vital organs. Key features: hemodynamic changes, reduced cardiac output, hypovolemia and decreased tissue perfusion due to blood loss or fluid shifts, hypotension and tissue hypoxia in severe cases. Hormonal changes: increased secretion of catecholamines, epinephrine and norepinephrine to maintain blood pressure. Elevated cortisol levels, promoting gluconeogenesis and inhibiting insulin secretion. Release of vasopressin and activation of the renin-angiotensin-aldosterone system to conserve sodium in water. Metabolic response: reduced metabolic rate to conserve energy, hypometabolism, and decreased oxygen consumption. The focus during this phase is fluid resuscitation and hemodynamic stabilization. 2. Flow phase, catabolic phase. This phase begins once resuscitation is complete and perfusion is restored. It can last from several days to weeks, depending on the severity of the injury. The body enters a hypermetabolic and catabolic state to mobilize energy for repair. Key features: increased metabolic rate. Resting energy expenditure may increase by 30 to 100%, depending on the injury severity, e.g., severe burns. Elevated oxygen consumption and carbon dioxide production. Protein catabolism, breakdown of muscle proteins to provide amino acids for gluconeogenesis and synthesis of acute phase proteins. Negative nitrogen balance due to increased urea production. Lipolysis, mobilization of triglycerides from adipose tissue as a source of free fatty acids. Ketogenesis may occur, but is often overshadowed by glucose utilization. Hyperglycemia, increased gluconeogenesis and glycogenolysis driven by cortisol, catecholamines, and glucagon. Insulin resistance, leading to impaired glucose uptake by peripheral tissues. Inflammatory response, activation of the immune system, and release of pro-inflammatory cytokines, e.g. TNF-alpha, IL-1, IL-6. Acute phase protein synthesis, e.g. C-reactive protein, fibrinogen in the liver. Clinical implications: persistent hypermetabolism and muscle breakdown can lead to significant loss of lean body mass. Adequate nutritional support is crucial to meet increased energy demands and minimize tissue wasting. 3. Recovery phase, anabolic phase. This phase occurs as the inflammatory response subsides and the body transitions into tissue repair and restoration of normal metabolic function. Key features: decreased metabolic rate, gradual return to baseline energy expenditure. Protein synthesis, rebuilding of lean body mass and repair of damaged tissues. Increased uptake of amino acids by muscles. Restoration of normal glucose metabolism. Resolution of insulin resistance. Normalization of hormonal levels. Reduction in cortisol and catecholamines. Resumption of anabolic hormonal activity, e.g. insulin and growth hormone. Clinical implications: adequate protein intake and energy support are essential for recovery. Physical therapy and rehabilitation play a critical role in regaining strength and functionality. Factors influencing the metabolic response. Several factors can influence the magnitude and duration of the metabolic response. Severity and type of injury. Larger injuries, e.g. burns covering 40% of body surface area, elicit a stronger response. Age. Elderly patients may have a blunted response. Pre-existing conditions. Chronic diseases like diabetes or malnutrition can impair recovery. Infection or sepsis exacerbates the hypermetabolic state. Management strategies. Effective management of the metabolic response to injury focuses on 1. Early resuscitation, correcting hypovolemia and ensuring adequate oxygen delivery. 2. Nutritional support, early enteral feeding to preserve gut integrity and reduce catabolism. High-protein diets to offset muscle breakdown. 3. Pharmacologic interventions, use of anabolic agents, e.g. growth hormone, insulin-like growth factor 1 in severe cases. 4. Control of inflammation, timely management of infections or sepsis. 5. Rehabilitation, physical therapy to rebuild strength and prevent deconditioning. By understanding and managing the metabolic response to injury, healthcare providers can improve outcomes, reduce complications, and expedite recovery.